here. Thank you all for coming. We have some great presentations lined up for you today, starting with Dr. Alexander Kowalski. He is going to speak on head injury and bewilderment. He is from Health and Law Resource Incorporated. Kathleen Majeski from Athletico will be next. She will speak on FCEs and the data accurately representing abilities. And then Dr. Rizwan, I might be saying it wrong, Orion from Illinois Orthopedic Network will speak on the evolution of the injury program. This will be our last medical seminar this year. And,
please.
All right, well, microphones. Sorry. Anyway, thank you all for coming. This will be the last seminar this year, and we hope you enjoyed the presentation. If you have any questions, I'm sure you all know how to get in touch with me. Thank you. Dr. Kowalski. You may have to fix the mic.
That's exactly right. That's exactly right.
Yeah.
Good afternoon. Can people in the back hear me?
Oh, yeah.
Perfect. It's a pleasure to be here today. I'll be talking about the head injury. Bewilderment refers not to what the injured individual feels, but what we feel when we evaluate one. The way that I like to present is I'd like to be interrupted, so if there is a question you have, just please raise your hand and I will call on you. I'll repeat the question if it's not loud enough and do my best to answer. Show of hands, how many individuals here have managed to work on a traumatic brain injury case? Oh boy. Speaking to the audience of people who have a great deal of experience. So if this is too basic, let me know. If it's too, not at the level you want, just ask me questions. All right, so question. Traumatic brain injury is a life-altering injury for survivors and their families, profoundly impacting the patient's neuropsychiatric status. B, a very common injury that is essentially inconsequential to the individual's neuropsychiatric status following recovery. And is this some kind of a trick question? Answer. Either one may be true. Depends on the case. It depends obviously on the severity of the injury and also the treatment that the person will receive immediately afterwards and subsequently. And thorough evaluation from the beginning is the key. If I go too fast, let me know. DSM-5, Diagnostic and Statistical Manual of Mental Disorders, published by American Psychiatric Association, has completely revamped the definition of the traumatic brain injury for the cognitive problems following traumatic brain injury. In 2013, it's very different from DSM-4-TR that we had prior to that. The definition is at the end of your handout from DSM-4 for comparison. What DSM has done is identified and went into a great deal of detail in laying out the criteria and the course of the disorder where it wasn't done so in previous editions. It also has established the criteria for identifying the physical insult to the brain, whether it is an injury or not. And so that is very helpful. And what I'm going to do, I'm going to skip some slides because I would like to address that issue first. So in order to diagnose major or mild neurocognitive disorder, and I will come back and we'll talk about what those are. But I wanted to touch, that's impossible to see, huh? I wanted to go through the 4 criteria to identify the event as causing a brain injury, or potentially causing brain injury. And it's a criterion D. There is evidence of traumatic brain injury, that is, an impact to the head or other mechanisms of rapid movement or displacement of the brain within the skull with one or more of the following: loss of consciousness, post-traumatic amnesia, disorientation and confusion, or neurological signs, such as neuroimaging showing that there is some kind of a bleeding in the either coverings of the brain or in the brain itself, a new onset of seizures immediately subsequent to the fall, significant worsening of the pre-existing seizure disorder, changes in vision, one very particular sign is the loss of smell, and of course paralysis would be a significant neurological sign. So here is the slide, and I have several of these from different organizations, and they all pretty much the same. Classifying the severity of the traumatic brain injury. We're talking about the physical event and immediate effect on the individual. All right. So mild traumatic brain injury, by definition, will have one of these 3, we're not talking about neurological symptoms. Loss of consciousness, less than 30 minutes. And you can see that for moderate TBI, it's between 30 minutes duration to 24 hours. Severe traumatic brain injury, that person is unconscious for more than a day. Post-traumatic amnesia. By the way, anybody has any question about what loss of consciousness is? No, it sounds like pretty basic. The person is not aroused. Right? We do what's called chest rub. You take your knuckles or take a key and you rub it on the chest bone, and the person does not respond. They have low consciousness. Post-traumatic amnesia refers to an individual forgetting what happened immediately prior to the injury and immediately subsequent to the injury. And the longer that period of time, the more severe the injury to the brain. So if it's less than 24 hours, it's going to be mild. 24 hours to 7 days, moderate. And if you don't remember things that have lasted more than a week, we are in the area of severe brain injury. Disorientation and confusion. Sometimes we'll talk about mental status changes immediately after the person suffered an injury to the head. Basically, the person may not be alert, he may be somnolent, somewhat sleepy. Is constantly go in and out of being sleepy to being alert. The person may not know where she is or may not know what time it is. There is a great deal of confusion. Any questions about, yes?
For each of these events, that either loss of consciousness or operation, would these be something that occur immediately after the injury, or would they occur remotely in time?
When we are talking about mild from, the answer is it's immediate onset. There are cases when this can happen hours subsequently to the injury. I forget the name of the famous actress who was skiing in Colorado. Pardon me? Yeah, Ms. Richardson. She fell, experienced some head injury, no particular symptoms, and later on, I think she lapsed into a coma because she had a slow bleed in the brain. And one thing about the brain and the skull is the very interesting fact. The skull is pretty tough. It's a bone. And then on the inside, for whatever reason, God made lots of very sharp edges. The brain is consistency of, I don't know how many people here know about aspect. It's a jello kind of thing. And so when the brain goes like this, the head goes like this, the brain hits these bones, both in front here and in the back, and there are lots of sharp edges, and you develop injury. Just dull hitting the brain also can develop injury called contusion. And you can see that on the CAT scan. That's why in emergency rooms, the ER doctor will typically do a CAT scan, not an MRI, because MRI shows what happens to the brain weeks and months subsequent to the injury. MRI initially is not going to be particularly useful. The CAT scan will show the bleeding in the brain, and that can be extremely useful in diagnosing and then treating the individual. All right. Now I'm going to go back. So before DSM-5, there was no diagnosis of neurocognitive disorder. This is something that was established with DSM-5 in 2013. And there are two types of neurocognitive disorder, a minor and a major. And the difference between the two is the difference of severity of the symptoms. Neurocognitive disorder, if you look at DSM, you will find that you can have neurocognitive disorder due to a variety of reasons. You can have neurocognitive disorder due to vascular abnormalities in the brain. You can have neurocognitive disorder due to an infection, such as HIV. You can have neurocognitive disorder due to variety of other medical conditions, which are all defined and discussed in DSM. The TBIs in DSM and in the field of psychiatry is addressed through that structure, the neurocognitive structure, the neurocognitive disorders. There is very limited amount of what psychiatrists evaluate when it comes to post-traumatic headaches, post-traumatic migraines, and other physical sequelae of a traumatic brain injury. That's where the neurologist will come in to evaluate and to treat. And neurologists tend to talk about concussive syndrome, where we in psychiatry do not use that term. And I will tell you that there is tremendous amount of controversy in the field. A lot of people would love to get away from the whole idea of post-concussive syndrome. It is extremely poorly identified with criteria. I will show you some criteria from one source. Okay. So mild neurocognitive disorder. Now, here is the problem with language. Mild is actually pretty severe to the person who has it. Mild is what we in psychiatry consider to be mild, compared to what will be severe neurocognitive disorder. So just to let you know that, so the criterion A, there is evidence for modest cognitive decline from previous level of performance in one or more cognitive domains: complex attention, executive function, learning and memory, language, perceptual motor, and social cognition. By the way, if you have not seen haven't looked at the DSM lately and have not seen the definition of each of these cognitive domains with examples of what mild and severe impairment in those domains will look like in real life, I strongly recommend that you do. It is very eye-opening because it kind of allows you to understand how, for example, what does it mean when somebody has perceptual motor difficulty? What will it look like in real life? And it may be helpful to you. Now, the definition of modest cognitive decline is defined in DSM-5 as performance and standardized neuropsychological tests between the 3rd and the 16th percentile. So if you are in 16th percentile, that means 84% of people will score better than you. 3rd percentile means 97% of people are scoring higher than you on that particular domain, cognitive domain. Now, how does this come to our attention? Mild neurocognitive disorder, let's say just not necessarily from TBI. The person himself or herself may complain that there's something wrong with the way they're thinking or functioning. It would be husband, the wife, children, whoever, saying, hey, listen, you're just not the same. And in order to really diagnose it well, and also in order to follow the progression, to see whether the treatment is working, it would be great to have neuropsychological testing done for that purpose. But if you don't have a neuropsychologist available to do the testing, there are things that we can do without neuropsychological testing. But it's better to have. In a mild neurocognitive disorder, the cognitive deficits do not interfere with independent living. Do not interfere with the ability to perform activities of daily living. They do require greater effort and various compensatory strategies in order to accommodate yourself to having these kinds of deficits. Now, a lot of us in this audience, I imagine, with progression of aging, don't remember names as well. Sometimes we have word finding difficulties and stuff like that. That is very common. It's not an illness. As we forget more concrete things, we become more global thinkers. So that's kind of nice compensation. There are some rule-outs here in order to diagnose it. You cannot have these changes during the delirium. Delirium is an acute brain failure, and it's not the topic of my talk today, but think of somebody who is withdrawing from alcohol, and they are seeing pink elephants and giraffes running around their room. That would be delirium. Their ability to concentrate, pay attention is severely impaired. If they have delirium, they cannot be diagnosed because they may have a neurocognitive disorder, but you cannot evaluate for its existence at that time, unless you have history. And it's very important, the criterion D, that the cognitive deficits are not better explained by another mental disorder. Human cognition is extremely vulnerable to presence of a lot of very different medical conditions, such as abnormal thyroid, side effects of various medications, high blood pressure, a large variety of things, and of course intoxication or withdrawal from various substances. So before we diagnose mild neurocognitive disorder, we have to make sure that there isn't something else going on. And I only mentioned the medical problems, but what about psychiatric? Right? People with major depression, their cognition is impaired. People who are manic, their cognition is impaired. People who have schizophrenia or other psychotic conditions, over time, their cognition is going to deteriorate quite remarkably and significantly. So it's not just worrying about thyroid or worrying about your blood pressure, you also worry about other psychiatric conditions that may explain problems with attention, concentration, memory, what have you. Now, major neurocognitive disorder, we got real problems. Now we have evidence of significant cognitive decline. Now we're talking about below the third percentile. So 97% of people will be doing better than the individual. And now you're going to have interference with independent living. So you will at least need somebody to help you cook. Driving a car is going to be dangerous, if not actually impossible. We're talking about a really significant decline in function. All right, so now we're going to go and put these two things together. We're going to take the head injury and possible consequences of it, either mild or major neurocognitive disorder. So you start with the fact that you have some kind of neurocognitive disorder, either mild or major. And then you have evidence that there was a traumatic brain injury. There was a hit to the head. Somehow the brain was potentially injured, but you have to look for one of these four symptoms: loss of consciousness, post-traumatic amnesia, disorientation and confusion, or a neurological sign. The most important thing in litigation, and I'm a forensic psychiatrist, as I'm sure many of you know, in evaluating the claimant, I am looking at witness reports, if there are any. I'm looking at the ambulance reports from emergency medical technicians or whoever evaluated them at the time of the actual incident, and then emergency room. And what I'm looking for are these criteria.
Doctor, am I correct in saying that if the patient, him or herself, is the only one who reports the loss of consciousness, then you don't take that into consideration? It has to be documented by a medical doctor at the time?
Well, it depends, right? It depends. So, for example, I will try to figure out how long that time has passed between when the person fell or had an injury and was found by someone or observed by someone. And if possible, figure out if, let's say, for the sake of argument, we'll say there was loss of consciousness, let's look at how long it might have lasted.
Right, but the criteria doesn't say more than any amount of time. It just says loss of consciousness.
Pardon me?
The criteria, which is a consensus-based document created by a dozen psychiatrists and then voted upon, doesn't say more than 30 seconds, right? It just says loss of consciousness.
Yes, it does, but in the body of the DSM, the definition of a traumatic brain injury, remember I showed you the tables? Let's go back to this for a moment. So this is the ratings for the severity of the traumatic brain injury. So if you have loss of consciousness less than 30 minutes, by definition you have mild traumatic brain injury. All right. So going back to this slide is that the first thing to do is to figure out what actually happened. Was there an injury, potential injury to the brain? Some of it is really kind of obvious, right? For example, if somebody falls off a certain height, there's plenty of literature to tell us you fall out of I don't deal with severe traumatic brain injuries, but let's say you fall out of a third-story window. I don't know exactly the percentage of survival, but it's going to be relatively low. But if you fall from a particular other type of height, what are we going to be looking for? Well, we're going to be looking for black and blue marks or some evidence of laceration, some evidence of injury to the head. And if there is one, then injury has occurred, particularly if you don't have any witnesses or you don't have any, particularly if you don't have any witnesses. But in an emergency room, documentation of physical injury to the cranium, that is the head, injury to the skin and the tissues overlying the skull underneath the skin. If you do a CAT scan, you will be able to diagnose swelling. Obviously, you can diagnose fractures of the facial bones or the fracture of the skull, which immediately tells you that the force that was applied to the head was relatively severe. It's not that easy to break a skull. Very traumatic amnesia. This is an interesting one. It's also subjective, right? Somebody can come to my office 2 years after the injury and say, I don't remember anything that happened for the first week after my accident. How would you know whether that's a true statement or not? Because we know how the brain works. If you are alert and oriented in all spheres, except under very few circumstances, your memory is working. And there is no reason for you not to have memory for the event subsequent to the fall. Some of the things that may interfere is if you're intoxicated, right? If you have a blackout. People during blackout don't have any cognitive problems that other people may observe. It's just that when they sober up, they don't remember what happened during the time they were drinking. But during the time of intoxication, they were walking, talking, driving the car, not so well perhaps. And there is nothing other than noticing that somebody is intoxicated that will tell you that they cannot lay down the memories. Yes?
Are you noticing any differentiation between short-term and long-term memory?
Post-traumatic amnesia is by definition short-term memory. The problem is you do not encode the information. Okay? So you forget what happens because you cannot form a memory. And that's why the fact that somebody is alert and oriented in all spheres is so important, because it tells me they are able to lay down memory. And therefore it becomes questionable whether or not the report of post-traumatic amnesia is authentic or genuine or not. Disorientation and confusion, that mostly comes from the witnesses, whether emergency personnel in the ambulance, police officers. It's very difficult to claim that you were disoriented or that you were confused when a police officer has documented what happened during the particular motor vehicle collision, and you were the one who was giving that history and it's consistent with others involved in that incident. So, all right. Neurocognitive symptoms have to present immediately after the occurrence of the event, or immediately after somebody lost consciousness, after they regain consciousness. So all these symptoms start right away. Why? Because we're dealing with acute brain failure. And those pathologies, those problems with functioning, start immediately. Other than if you have slow bleeding, that obviously can cause problems that will arise later on. When we talk about more physical symptoms, post-concussive syndrome, the symptoms can arise within 3 to 4 weeks, but not further than a month subsequent to the injury. Any questions?
The connection between those 4 symptoms that you put up there, it's an or, right? It's not an and.
Yeah, totally correct.
So it's any one of those 4.
That is correct. Here's the problem here. So, loss of consciousness is clear. Post-traumatic amnesia may not necessarily be a symptom of a physical injury to the brain, right? It could be dissociative amnesia. Now, one thing we always talk about, these events occur in the person, it's TBI or no TBI. But there could be other things as well. There is absolutely no reason when somebody experiences an event that they feel may have caused them death or serious injury, they may develop post-traumatic stress disorder or acute stress disorder or some other trauma-related disorder. So we're not just limited to traumatic brain injury. And actually, there is a significant overlap between traumatic brain injury symptoms and acute or stress disorder or post-traumatic stress disorder. And then, again, I already mentioned there are a number of other conditions you can develop, and so the differential is, and I have a slide on that, differential is relatively extensive. If you have disorientation and confusion, again, it could be dissociative symptoms.
But I just want to clarify that loss of consciousness is not a required element to make the diagnosis of traumatic brain injury. Is that correct?
That is correct. As long as you have one of the other three.
I got it.
Aye.
You are speaking, I think it's fair to say that you have a high level of expertise in knowledge and a critical eye in evaluating and diagnosing and treating these patients. But what bothers me in part about what you said is that it seemed like there's a credibility issue immediately subsequent to the traumatic brain injury. And the credibility is between what the patient reports as the history as opposed to perhaps the emergency person or the emergency room doctor who might not have the same critical eye and level of expertise as you. So it seems to me that after these things occur, you're potentially, in what I heard from you just now, more reliant on what the EMS person says or the ER doctor says as opposed to what the patient reports.
Mr. Stone, you and I went round and around on these issues. Before I would make a diagnosis of any sort, right? Those of you who have proposed me or hired me, been to the lecture site, have given, in the forensic psychiatric academy, there are 3 independent sources of data. The records, which is emergency technicians, physicians in the, and other medical personnel in the emergency room, treating doctors, what have you, both before and after the injury, as well as depositions and whatever. Then there is neuropsychological and/or psychological testing, which is independent of what I will find in the record. And then there is a forensic psychiatric interview, a relatively sophisticated procedure to obtain information about what happened, what were the symptoms, what they felt like, and in every aspect of the IME or the evaluation, you're looking for congruence. If the records are consistent with self-report during the interview, and they are consistent with the results of psychological testing, you got what you got. The problem you get into, I get into, right, where I actually have to start thinking more, is when 2 areas give you one answer and one gives another. And you need to figure out why that is. But one does not make a determination just based upon one single fact. The only single fact that has significant influence is a particular kind of tests or effort. And if it is of particular, it gives you a particular kind of result, then the person's credibility is shot. Now, another, I think, very reasonable question is, why be concerned about truthfulness of the injured workers report? Because the evidence is that between 30 to 40% of injured workers who are in litigation are, to some degree, exaggerated or malingering. And so the field is very focused on being able to identify individuals who are not being particularly truthful. Okay, I have a couple slides here. I hope those of you who have a handout are able to read it. I myself cannot even read it. Give me 1 second, I'll get my slide. So this is on page 15. This is on page 15, and it's a very important slide because it tells you all kinds of conditions that you need to take a look at in order to figure out whether or not somebody had a traumatic brain injury and what complicating things might be occurring. So obviously pre-existing medical and neurological conditions that can alter consciousness. For example, somebody can fall because they have hypoglycemic episodes. They didn't trip, they just fall standing up, go down. They have a syncope episode, but that's because they had very low sugar. Why did they have low sugar? Well, obviously the first answer is diabetes, and they may have taken too much insulin. Also could be alcoholism. And there are a number of other conditions where people will develop hypoglycemic episodes and will fall. And the fall may not be the cause of their subsequent symptoms, because there is such a thing as alcohol-induced dementia, but there's also alcohol-induced brain damage. You don't necessarily have to become demented immediately, but you will have problems with memory and attention and concentration. And therefore, figuring out the causation becomes important if we are in a setting, legal setting. Being dehydrated or being hypovolemic, same thing, also can cause an event that can either cause you to fall and cause a variety of symptoms consistent with TBI, even when you didn't have a TBI. I'm not going to go any further in this slide, but I encourage you to take a look at it. It's not as obvious that somebody fell and they have developed symptoms, that there is this direct correlation between the fall and there was nothing else going on. I mean, seizure is another example. Okay, so what kind of things go bad for people who have traumatic brain injury? And I'm not talking about mild traumatic brain injury. Processing speed, complex attention, declarative memory. Declarative memory is memory for facts. Executive functioning, and that is overall judgment, as well as social cognition. And again, I strongly encourage you to look at the DSM. They have this table with examples of what each of this cognitive domains is actually, how does it show itself in real life. That's more important than how it shows on the testing. So it helps to understand the results of the testing, whether it will affect the person in real life, particularly if we're looking at individuals' impairments and disabilities. People with traumatic brain injury frequently develop behavioral disturbances. They can develop delusions, hallucinations. They can become depressed or manic. They can become very unstable emotionally. agitation, disinhibition, wandering, or apathy, all possible behavioral disturbances, but not something you see in a mild traumatic brain injury. So here's more. You can have fatigue, headache, photosensitivity, sleep disturbance. Sleep disturbance is probably one of the most pathogenic events, because if you don't sleep, everything else gets out of shape. And so when we treat individuals with mild TBI or more severe traumatic brain injury, making sure that they sleep well is really important. These symptoms, the emotional symptoms, as well as some of the physical symptoms, tend to resolve in mild traumatic brain injury on the same schedule as cognitive symptoms, and that is at most 3 months. And that creates a lot of, now that's a big issue in litigation. There are no reliable data that will tell you that, other than, and I'll mention it, what's called complicated mild traumatic brain injury. People should go back to normal typically within days. Sometimes weeks, at most 3 months. If a person improves and then they develop worsening of their symptoms, this is not related to the traumatic brain injury, something else is going on. And this is why we frequently look at the longitudinal course of symptomatology. As the person is improving, as time goes by, day by day, week by week, and then suddenly there is a drop, and all hell breaks loose. Wherever it is, it's not TBI. Not that TBI. I'm not going to talk about the behavioral disturbances in moderate to severe TBI. Those cases typically do not bring as much conflict as mild TBI. Symptoms in moderate and severe TBI typically like that is to need to die. This is a very interesting graph. And what it shows is the vector of improvement. So to your far left on the slide, you see how quickly people with mild TBI improve and achieve pre-injury status. Moderate TBI has a different slope, takes longer, and severe TBI even longer. In moderate to severe TBI, we're looking at anywhere between 18 to 24 months before a person will achieve a plateau, after which there will be very, very little improvement expected. Improvement does occur for up to 5 years after the injury, but we're talking about several percentage points. So by the time you have a year and a half, 2 years after the injury, that's about where the person is going to be for the rest of his or her life. And again, that's from moderate to severe TBI. I talked about a complicated mild TBI, and that is a mild TBI by the criteria, but where you have evidence of physical injury to the brain on a CAT scan or an MRI. There is no one-to-one correlation between, sometimes we see people who have the most horrendous injury, multiple broken bones, facial bones broken, losing their eyes, what have you. But cognitively, they're perfectly fine. And you ask yourself the question, how is it possible? Somehow it's possible. It's really, you always look at the actual functioning to see how the brain is working. I mean, there are stories of people who have absolutely normal life, and on an autopsy you find that half of the brain is gone. Some of us don't function well even with all of it there. I finally got a chuckle from someone. The other thing to be concerned in mild TBI is that if it's a repetitive mild TBI. Okay? So everybody, it's an old story now in athletes, they don't necessarily have moderate or severe TBI, they have what in that field is called a concussion, but you have several of those for a long, multiple of those over a period of time. You can even develop dementia. And those of you who like boxing know about Lugha Ristica. I forget the term, but it's dementia due to boxing. And the individual doesn't have to be knocked out for more than 30 minutes, right? It's short knockout, but it happens 50, 60, God knows how many times over a lifetime. And these people get into a lot of trouble. The last point on this slide, most people with mild TBI recover fully and do not develop either mild or major neurocognitive disorder. And I know this statement is going to come back and haunt you during the next deposition, but it is the fact, and you have to look at other factors, such as a complicated TBI, but then of course, other causes, other explanations for the symptoms, including not being honest. Putting it all together, I think it's more confusing than not. If you have moderate to severe TBI, you can develop other psychiatric conditions. Some people become paranoid, some become psychotic, some people develop bipolar disorder. It's relatively controversial because it's so difficult to really figure out what was what. Just because you had a brain injury at one point and then sometime later you develop some kind of a condition, that does not necessarily mean that there is a causative connection biologically. Post-concussive syndrome, this is from ICD-10, and that talks about history of head trauma with loss of consciousness. So according to ICD-10, you have to have loss of consciousness. And within the first 4 weeks, you develop one of these 3 clusters. Set of symptoms within these clusters. I included post-concussional disorder criteria from DSM-4. It's mostly for academic interest because there is no longer post-concussional syndrome in DSM-5. And I have a few minutes. I'll be happy to take any questions.
What's the status of the research and your experience from the related situation, let's say going back to the 70s, what categorize it as a mild head trauma or head trauma, and a very delayed or significant delayed psychiatric major depressive result. You address the, you talk about the extended trauma, but it's more in the TBI as opposed to a depressive episode. And I saw you made reference to psychiatric conditions. But it seemed to be big in the 70s with research, I'm giving away my age, but what's the state of that research now?
It hasn't progressed very much because the difficulty has remained the same. It's very difficult to make a causal connection between one event and another event, where there is no biological. So, for example,
No biological, right? No
right, there is no biological. Well, for example, if you have a severe traumatic brain injury, you have multiple impairments, your life has changed horribly, and you develop depression, few people would argue that there is no connection. Okay, particularly if the person legitimately tells you, I used to be a physician, and now I'm sitting in a wheelchair. Okay, if you're not depressed, tell me why not. I'd love to figure it out and give it to my other patient. But we're talking about a biological connection. Something gets broken in the brain, and you develop depression, you develop psychosis, for example. You may even develop manic symptoms. In my career, I had a few people. Go ahead.
Well, I've seen this, you said the psychosis. Those are the cases that I saw and later ruled upon where it is a very strong psychosis. Very few cases, but nonetheless, it was always after that 6-month mark. And the research out of Loyola and different places locally was let's explore that. So that's popular.
Yeah.
You said I'm keying in on the psychosis.
There are several textbooks on psychosis after traumatic brain injury. There is a lot more data. I think that in case of a serious head injury followed with psychotic symptoms in short proximity without pre-existing psychotic phenomena, it's probably connected.
Second quick point in regard to the constant dialogue that emphasized by you and Mr. Strom, that making your both great points is this. Everyone in this immediate area has probably ruled on a number of cases, it'd be almost 1,000. And as the years went on, I was so dismayed at the progression of electronic histories and histories taken by, at this point in time, non-medical personnel. We're not talking about nurses, we're talking about people in green sweatsuits with their laptop or their little machine. And the poor physician at deposition or record has to rely upon this terrible situation. So you're in a dilemma and we're in a dilemma. I just want to know it's just getting worse. That's all I have to say.
I couldn't agree with you more. I have to read like you do. I have to read reams and reams of electronic medical records and all the cut and pasting that's going on. And it's just also mind-numbing, all these particular questions, yes, no answer. Who the hell can process it?
Well, who wrote it? That's the problem. The doctor's signature is on it, but it starts at the lowest level of clerk in the ER.
You're absolutely correct. In emergency room, typically the physician will be the one making the final note and do their own exam. And then, depending on the institution, for example, VA, in my opinion, have a very bad electronic medical system. But other institutions have better. Thank you very much.